So Gerardo, it's your turn. We talk about a normal ECG, we talk about inverted T wave. Gerardo will talk about the other aspects of the electrocardiogram.
All right, so in the next 20 minutes or so, we'll talk about abnormal ECG findings in athletes, and of course I will not discuss the T-wave inversion as Professor Pelliccia already did. So now we will focus, we've seen before the green and the orange box, now we will focus on the red box. All right, so first of all, I would like to discuss about ST depression. So ST depression has always to be considered abnormal in an athlete. So ST depression more than 1 millimeter has to be considered abnormal, and so further test has to be requested, so like an echocardiogram to rule out a possible heart disease. ST depression may be caused by various reasons. We can have ischemia, strain, cardiomyopathy, electrolytic imbalances. I would say that often when we see a young individual where there is ST depression that is localized, we have to rule out a possible cardiomyopathy. And for example, we can see this ECG. This is an athlete that is followed at our clinic in London, and we see quite clearly that there is an ST depression in V3 to V6 and in the inferior leads, and this athlete has been diagnosed with dilated cardiomyopathy. He had an ejection fraction of 40%, and it was there was also late gadolinium enhancement at the MRI. So ST depression has to raise the suspicion of a possible heart disease. Then pathological Q waves. And also here, pathological Q waves, we will discuss about the definition of pathological, but Q waves should raise the suspicion of a possible heart disease. And again, when we are talking about young individuals, even if, of course, when we think about Q waves, we think about myocardial infarction. If we're talking about young individuals, young athletes, pathological Q waves should raise the suspicion of a possible cardiomyopathy. And again, this individual has been diagnosed with a cardiomyopathy, and specifically hypertrophic cardiomyopathy. And we can see quite clearly that there are Q waves in the inferolateral leads. So how do we define a pathological Q wave? So first of all, a Q wave on the electrocardiogram is an initially negative deflection on the QRS complex. And a Q wave is defined as pathological if it is more than 25% of the respective R wave in depth and more than duration more than 0.04 seconds, so more than 1 liter square in 2 leads, in at least 2 leads except AVR. What about complete left bandage branch block? We discussed before about right bandage branch block, and we said, okay, if we have an athlete with right bandage branch block, we can consider it as a normal finding, but left bandage branch block is always has always to be considered an abnormal finding, so further test has to be requested. So it is defined, of course, about as a QRS duration more than 120 milliseconds, dominant S wave in V1, and broad monophasic R waves in the lateral leads. So complete left bundle branch block is found in less than 1 in 1,000 athletes, but instead is a common finding in cardiomyopathies. And specifically, dilated cardiomyopathy probably is a condition where the left bundle branch block is more commonly found, as it is shown by this study from the Trieste group, which showed that 31% of the patients with dilated cardiomyopathy had a left bundle branch block, and 11% developed left bundle branch block during follow-up. And also left bundle branch block was a predictor of mortality. So LBBB always requires a full diagnostic workup to rule out a cardiac disease. Ventricular pre-excitation, it is defined by the presence of a short PR, so less than 120 milliseconds, and a delta wave. And we can see it better here. So delta wave plus short PR. And of course, it's an abnormal finding in athletes and in sedentary individuals. It's one of the most common findings during ECG screening in young individuals and in athletes. So we have to be trained to recognize this pattern. Of course, the WPW ECG pattern is secondary to the presence of an accessory pathway between the atria and the ventricles. And often when we do ECG screening, for example, 2 days ago I was in a school in London, and we screened 100 young individuals in one day, and we found 2 WPW patterns. So it's quite common. And these individuals didn't have any symptoms at all. So they just arrived, no palpitations, no syncope, 16 years old, and they had this pre-excitation pattern. So I think it's very important to remember that the presence of symptoms is not particularly useful in determining the outcome. And of course, in the area of ablation, probably ablation and at least an EP study should be considered in all individuals with pre-excitation. And also, as this study showed, the study on the right, there is a small risk of sudden cardiac death in individuals with pre-excitation with WPW ECG pattern. So we have to refer the athlete or the young individual for further tests. What about the QT interval? So QT interval is considered to be abnormal in athletes, more than 470 milliseconds in males, more than 480 milliseconds in females. And here we have a clear example of abnormal QT. It is very important to measure correctly the QT interval in athletes. And it can be particularly challenging to measuring correctly the QT interval in athletes because there are often quite significant U waves that are very close to the end of the T wave. And of course, the bradycardia, the significant bradycardia, may be a source of challenge again for the measurement of the QTC according to the Bassett formula. And I think it's very important to remember that we have to teach the tangent and exclude the tail, as it is said by Michael Ackerman. So we have really to measure the QT interval in this way. So we have to eliminate the tail of the QT and draw the tangent from the T wave. So if we don't do that, of course, we would have overestimation of the QT interval. And of course, we are very concerned if there is a prolongation of the QT interval, especially for the long QT1, because there is an association with exercise-induced arrhythmias and sudden cardiac death, where the adrenergic surge, of course, is one of the main trigger of sudden cardiac death. Of course, the QT interval, the long QT syndrome is not diagnosed only on the prolongation of the QTC interval, but there are several criteria that have to be considered. These are the Schwartz criteria. So the presence of symptoms, arrhythmias, family history are all important in determining if somebody has long QT syndrome. So not just the QTC interval. And as I said before, there are some particular diagnostic challenges in long QT syndrome in athletes, in diagnosing long QT syndrome in athletes, because first of all, because 15% of the population has borderline QTC, 25% of long QT syndrome patients may have a normal QTC, and then there are issues also in underestimating or overestimating the QTC interval with the Bassett formula. Then we can have bradyarrhythmias. We discussed before about bradycardia. We said that bradycardia is absolutely normal in athletes, as well as sinus arrhythmia. We have to investigate only if the heart rate is less than 30 beats per minute. Generally, even if first-degree AV block and second-degree AV block type 1 are considered to be normal in athletes, Mobitz type 2 AV block and the third-degree AV block are considered to be abnormal in athletes. So we have always to further investigate these individuals. Then the Brugada pattern. This is a classical example of an athlete diagnosed with Brugada pattern. We know that Brugada syndrome has been first described 25 years ago, and particularly the association between sudden arrhythmic death syndrome, so normal heart at the post-mortem of individuals that die suddenly, often during sleep. The association with a particular ECG pattern characterized by right-banded branch block with J point and ST elevation in V1, V2, and polymorphic VT and VF. Here we have a clear example of the three types of Brugada ECG pattern, and we have to remember that only the type 1 Brugada ECG pattern is diagnostic, is significant. The type 2 and 3 are not diagnostic and not significant. However, when we usually see an athlete that has type 2, type 3 ECG pattern, we always try to do a high lead ECG, so we move the leads to the third or the second intercostal space to rule out a possible Brugada type 1 pattern. So normal finding type 2, type 3, the only one that is abnormal is the type 1. And of course there are challenges in the differential diagnosis between athletes and Brugada ECG. And because, as we have seen from the previous presentation from Professor Pelliccia, there is often, especially in association, in combination with T-wave inversion in the anterior leads, there is a J-point elevation that is quite significant in athletes, especially of Afro-Caribbean origin. However, the ECG pattern in Brugada syndrome and in athletes is different. Why? Because if we consider the J-point elevation, the ratio between the ST elevation at the level of the J-point elevation and after 80 milliseconds, this ratio is more than 1 in Brugada, while in athletes this ratio is less than 1. So this is a quite good, simple way to recognize Brugada pattern from J-point elevation and ST elevation that is typical of athlete's heart. Then finally, ventricular ectopics. So we tend always to further investigate athletes that show more than one ventricular ectopics on a 10-second 12-lead ECG. However, we know that ventricular ectopics may be quite common in athletes, and and also in young individuals, and they are generally not associated with cardiac disease. We tend to do an ECG and an echocardiogram. We tend to do an echocardiogram 24-hour Holter if there is more than one ventricular ectopics anyway, just to rule out a possible cardiac disease. And we have to think about pathology if the ventricular ectopics are polymorphic and repetitive on the 12-lead ECG, if they do not change with the training, if of course they are associated with symptoms as palpitation or syncope, or if they are associated with ECG abnormalities or echo abnormalities. Thanks for your attention.